Good morning, everyone. My name is Deborah Ward, and I am the CEO of the YWCA of San Gabriel Valley. I welcome you here, and I'm also going to start our first panel of the day. I would like to call up our speakers, Dr. Oakes, as well as Ms. Martinez. How's everybody doing this morning? Great. I always like to get a temperature of the room as part of, I didn't quite introduce myself fully, but I've been a part of the Domestic Violence Leadership Council for a number of years. One of the original grantees when I was working with Genesee back in the day. And YWCA was also a partner, so to be able to lead that organization and to continue to lead this work in a way to collaborate with our healthcare brothers and sisters and organizations throughout Los Angeles County. It has been a great pleasure. So with that, I do want to just get a temperature of how many healthcare providers are in the room. Can I shout out some healthcare providers in the room? Come on. Let's give them a hand. Thank you. I see a couple of FQHCs in the room. And then how about human service organizations? Great. Domestic violence shelters. Okay, thank you, thank you. This is really an effort to talk to each other, and we hope that throughout the conference that you're able to network and get an opportunity to meet others and collaborate and talk about our different issues. So we're going to start off with our first panel. The format today, I'm just going to give them a few questions because we don't have a lot of time. But we want it to be interactive. So you have on your table the index card, kind of went old school. So those of you that have index cards, as we're going through the panel, if you have questions or you have an idea that you wish a healthcare provider would do this as it relates to centering survivor services, put the idea on that. And we'll have people throughout the room that will be collecting those. We might not be able to get to all the questions, but we'll do a few towards the end. So also, as part of this format, you have an electronic program, and you also have a hard copy at your table. Please remember that I'm not going to read the bios. Please go directly to the program to get the full bio, and it's worth going through their backgrounds. So we have two ladies here. One is Dr. Lisa Oakes from Kaiser Permanente, and she is also the director, the regional physician leader for Kaiser in their family violence prevention program. And we also have Blanca.
It's early.
I got both doctors. We have Blanca Martinez, and she's with Molina Healthcare California, and she's the director of case management and care management for them. So I'm going to start off quickly with the first question, and we'll give you both an opportunity to answer that. Please share a little bit about your organization. Both of you are with health plans, and your best practices and priorities around your organization efforts to support survivors.
Yeah? Oh, there we go. I don't really like hearing my voice, so I'm going to kind of keep it kind of far away. Well, good morning, everyone. We're both really excited to be here, to learn from you all, to hear how we can better partner I'm the director at Molina Healthcare, and so I oversee about 100 staff who are working closely with our membership, so our Medi-Cal members. And they're bilingual. They live within LA County and other areas, since Molina's footprint is throughout California. And their background is social work, LMFTs, nurses, and other disciplines. So what we do is upon enrollment, so when a new member enrolls, we do send them a screener. We outreach to them to try to assess what their needs may be. And within some of those screeners that we do, we are assessing for, are you in danger? Do you need resources? Do you have mental health needs? Our staff is trained. They come from various settings, and we're a multidisciplinary team, and so the staff are able to assess and work closely with some of the agencies out in the community to help our members. So that's a little bit about what we do. We do provide trauma-informed training as well, and other trainings that are relevant to really help our staff be aware and know how to engage with the community as these issues come up.
Blanca? Hello? Hello? Oh, there we go. We got it. Thank you, Blanca. I'm Lisa Shillian-Oates, and I'm a family medicine physician in Orange County. And as Deborah said in her wonderful introduction, I am the physician leader for our family violence prevention program. So Kaiser Permanente has a very large footprint in Southern California, as you're probably aware. We extend from San Diego all the way up to Antelope Valley. It's about 13 medical service areas, and somewhere in the range of 20,000 physicians, 200 and some thousand employees, so we're very large. And we've had a family violence program for about 15 years. And our program is, the title Family Violence is an umbrella for kind of a three-pronged approach where we have an intimate partner violence team and a child abuse prevention team, as well as an elder and dependent adult prevention team. And so I think one of the strengths of our program is that we really recognize the dynamics that these often are co-occurring in families, and that it's cyclical and intergenerational, and so really try to bring together all of these topics in one. And so when we present to our audience groups, whether it's our physicians or staff, we really bring that approach and that philosophy to our presentation, so that we're helping them connect the dots, and really encouraging that interdepartmental communication and collaboration in approaching these issues. Because if there's a woman in the household who's being abused, there's often children that are also experiencing that abuse. And in many families, there's also a third generation there, a grandparent, an uncle, something like that, who's also in the home and also, experiencing the effects of that, even if they're not directly being abused. So I think that's one of the real strengths of our program. The other thing that we really do is recognizing how experiencing trauma or violence or abuse at a young age impacts health throughout the lifetime. And I'm sure everyone here is familiar with ACEs and how that work was initially done in Kaiser Permanente in San Diego. And Unfortunately, it's taken 25 plus years for that knowledge to sink in, but it has. And so we are now screening and addressing ACEs in pediatrics and adult primary care, and fingers crossed in our prenatal settings as well in the near future. So that's another thing that I think we've really listened to the learnings of the past and really trying to incorporate that into what we do on a day-to-day basis.
If I can just say something, sorry. And this is for all Medi-Cal health plans. The Assembly Bill 1184 really also protects this cohort, meaning that if they wish to receive their mailings at a different address, or if there's certain information that they don't want even the primary insurer to know of, there is a form that can be completed and sent to their health plan, and that will be honored. So I'm kind of assuming you guys know about AB 1184, but just in case, I figure that that would be really important to share, since that is a way for individuals to feel, I guess, safer when they are seeking care, through their primary care physician office or a specialist.
Thank you both. Hello?
You have to sing.
Testing.
You have to sing, and then it
See?
turns on.
Only if we want to clear the room. So, okay, there it goes. So many of you know the title of this workshop or panel is Breaking Barriers to Access to Quality Care. And in the room are a number of human service, domestic violence providers that really want to extend an olive branch to our healthcare partners. And we know in many cases, our experience has shown that the healthcare structure really isn't built for survivors. And I'm hoping that maybe you all can speak on, from your perspective, what are some of the barriers that you all have experienced?
So I'll go first this time? Sure. All right. So despite the many years of doing this work and really trying to spread awareness and knowledge and comfort level addressing these issues in the healthcare setting, let's be honest, it's still very much under-recognized, under-reported, and undertreated, right? Some statistics say that more than 95% of victims or survivors getting healthcare go unrecognized, right? So it's a very small percentage. So really working on, why is that happening? And the reason it's so difficult is because there's a lot of reasons, right? So some of that is on the survivor side, so stigma, fear of what's going to happen if they tell somebody. Is this going to be reported? Are the police going to be called? Is my partner going to learn about it either, through what's released on my health record or through something that inadvertently it's going to be disclosed somehow. Also, trust, right? Not, feeling comfortable with the provider they're seeing, not thinking they're not going to be believed or they're going to be blamed. So, and then also, I think more difficult is on the provider side. So also fear of what's going to happen if they do disclose. I don't want to make it worse for them. It's none of my business. I don't know what to do about it if they tell me, right? I can't help them. I can't fix it. So all of these issues are there. So I think figuring out how to answer all of those barriers on an ongoing basis is really our challenge. And I think moving towards more survivor-centered ways of having these conversations, right? So when we first started doing it, it was very much kind of a routine screener, which is not often very friendly or trust building. But in the early days, that was the way we sort of pushed the conversation, right, and got people comfortable saying the words and bringing up the topic. But now I think we need to move past that into something that feels a lot more survivor-centered, a lot more meeting people where they're at and providing the information that they need at the time that they need it. So those are still our struggles, and one of my hopes today is maybe to get some ideas from you and some feedback from everybody out there who are doing this work a lot more often than I am, to get your ideas and feedback.
I mean, I agree as well, that the awareness and the training is really needed on our end. And I think even for, like, I think of myself and our staff, many of us lived in an environment where we saw our mother, for example, being abused. And so could be a lot of countertransference, fear of, I think just wanting to go there, if that makes sense, right? Wanting to talk about it. And so I think for my staff, that would be something that would be really helpful, is being able to have some of you all, as you are experts in this field, come and speak to us, train us, and potentially even provide some type of counseling. Maybe we can just kind of figure out how can we partner together and work together, and with us sharing our needs, how can you help fill that gap?
So thank you for that. I think as we kind of transition into the third question that I have, I know that in our experience with working with our healthcare partners, that systems change is hard. And if structures are not built for survivors, there has to be some courageous policy changes. I wonder if you all could just speak to some expansions that are going on in your organization, even if it's a pilot, as it relates to survivor-centered programming and services.
Things I wanted to share was we did partner with an agency in Long Beach where we paid them to service us. So for example, without going into too much information, so if we had meetings, they would cater for us. And so it was a workforce agreement, and the residents were able to receive payment for that and feel like they had, employment. So that was something that we did that I thought, it helps both of us, and then it allowed us both to be able to in-service each other, cross-train each other, and just bring more awareness to both entities.
So there's a couple of things that we've done in the past and then are looking towards doing, which I hope will break some of these barriers and move us towards that larger system change. One pilot project that was done and showed actually really, really great success was having a shelter, a DV shelter advocate housed in one of our medical centers, where there was an emergency room as well as outpatient clinics, and that allowed kind of real-time consultation and counseling for victims or survivors when they were identified, and also because our physicians knew that advocate was there, they kind of felt like, okay, they have somebody who can sort of take over the conversation. All they need to really do is identify somebody and get their buy-in, and then they could sort of hand it off. And so with that pilot study, we showed that the numbers, identification numbers rose, satisfaction on both sides of the equation increased as well. So that was a great model and really showed how important it is to have content experts and people who have knowledge and skill around talking about these topics, how it helps everybody, in the system. And the other thing, this is actually quite the opposite of that, but the other thing that we're really looking at and figuring out how to do is by providing information and screening electronically, like asynchronous from interaction with their healthcare provider. So there's a lot, statistically, I'm sure many of you are Kaiser members, and so we have this very strong online platform. kp.org provides a lot of information, a lot of communication access from home and outside of the medical center, and so there's been some success in providing screening and education around substance use and abuse, drinking, and smoking. So looking at those successes and seeing, is there a model or is there a place here to do relationship education screening, right? Like talking about it in the context of how healthy is your relationship, and this is what healthy relationships look like, this is what unhealthy relationships look like, these are red flags, that kind of stuff. And then providing opportunities for people to self-select, like, oh, I want some more information about this, I'd like to talk to somebody about this, I have more concerns about this, and then providing avenues for whether it's talking to their physician or talking to a behavioral health specialist or getting information from a community agency or getting connected to a hotline or whatever it is. So looking at possibilities there, and maybe that is a way of getting around a lot of those barriers I brought up before. So we will see.
The other thing I wanted to share is recently under Medi-Cal as well, thank you, the doulas became a benefit and community health workers. And so I think there's an opportunity there for us on the healthcare side to maybe hire more focused doulas in this area and community health workers and determine how much screening can they do to help us identify individuals that need help. So that is another area that I would love to hear from you guys, what ideas you guys have so that we can work together. And when I say we, I mean healthcare. It's not about my health plan, So just to be clear for all of us, since it is a benefit that we all offer and is available in the community.
Thank you. At this time, I would like to extend, if anyone has any questions or any ideas that they would like to present to the panel at this time. If you wrote anything on the index cards, if you could just raise your hands, and we have some of our hosts that will come by and pick them up. So while we're doing that, I do have a follow-up question. As we talk about expansion and looking at systems change, I wonder if you could talk a little bit about funding and how maybe healthcare could look at innovative ways to identify a larger pool of funding for this population. As you look at expansions cost, and is there a priority for this population to direct funding to services?
Maybe Kaiser, they have a lot of money.
Yes, we do. I'd say, the tough part about this in an organization like mine is that we rely strongly on evidence-based decision-making, right? And it's really hard to show the cost savings for doing something like interrupting the cycle of violence and helping somebody become safer and healthier. There is evidence that leaving an abusive relationship and becoming, getting into a safer environment actually does improve your health. It decreases utilization. We do have those. We have those studies, but often the realization of that is a very long-term process, and so it's just something that doesn't rise to the top of the priority list when people are when people are allocating their money. Unfortunately, I'd say the success of our program is very much on the backs of passionate folks who do this work because they have a real love for it, and we figure out how to do things with very little money, and I think we'd all love it if there was more money available, for sure.
And I think one thought that I have while preparing and coming here was, especially in LA County where we have multiple health plans. So we've got HealthNet, and then we've got LA Care, and then we have the sub-plans under them, like Molina's under HealthNet. It would be, I think, helpful to meet together and figure out how can we support this cause, how can we financially as well, and then also lobby. I think there's power in the health plans uniting, and Kaiser too, because they're in LA, uniting as well.
Thank you. I think another idea that you could think about is, I think we talked about it in our prep meeting, in terms of how you utilize non-profit health plans that have to do community benefit. That tying your contributions to the community are pilots within the domestic violence community is a way to get that evidence base, or at least seed it, to bring it to scale. So that could be one item. So those are the types of ideas that we're kind of looking at. We have a couple of questions, a couple of thoughts. What are your thoughts about medical mandated reporting as a barrier to accessing health care? And what are your thoughts about ending or limiting medical mandated reporting?
Ooh, this is a hot button. Okay. Please don't attack me in the lobby.
We're all friends.
I definitely feel that there's a lot of problems with the way our law, the California law, is written right now. And I definitely support revising that law and changing it so that it is much more survivor-centered as far as what needs to be reported and how that is handled. So definitely, I don't like the way it is now, and I'd like it changed. I am not comfortable with completely eliminating mandated reporting. I think it serves a very important role in healthcare. And it is, unfortunately, it is one of those sticks we use, right? Into this is why, doctor, this is why you need to know about this. Doctor, this is why you need to ask about it. And this is why you need to know what to do if it comes up. Because there's this mandate, this legal requirement for you to do this. So that's one aspect. But I also feel that in cases of severe injury, lethal weapons being used, that those survivors, those victims, survivors are in high danger, and often they don't recognize or can't confront the amount of danger that they're in, and so you need somebody outside of that situation to impress upon them the level of danger that they're in, and provide them with the legal resources that they need in order to to keep themselves as safe as possible. Are there problems with it? Yes. Are there problems with the way law enforcement responds in many situations? Absolutely. And I think that definitely needs to be changed. But I do feel that there's an important role there that I would hate for us to walk away from because of the problems that exist right now.
I can move to the next question. I'm going to put these together, combine them in some kind of way. Do your organization pay for in-house DV advocates, one? And two, does your organization have any forensic nurses for survivors of DV?
Should I go first? Because it'll be easy for us. So for us, it's no, but I know you do.
So we do not pay for in-house advocates, although we do have in-house social workers in many of the departments, embedded in the departments, as well as social workers and case managers in the hospitals. And so a lot of my program's work is keeping them up to date and educated on these issues, and so that they function as our embedded content experts. And then, no, we do not do any forensic examinations in-house. We refer to the county agencies.
All right. Next question is, as a survivor-centered approach to screening is being developed, how is it being informed by survivors? Like, do you have a survivor advisory board? Can they provide input into the process? How does that inform any internal policy changes?
Mm-hmm. So we do have patient advocate program, advisory council, patient advisory council. I have yet to meet any of them that are actual survivors themselves, although many of them will talk about how their children or their loved ones or other family members are survivors. And I think the demographic makeup of the folks that serve on our advisory council is one that it's a limited pool of people. So I have not yet met one of them that is on the advisory council. Personally, I serve on the board of one of our DV shelters in my community, and so in that role, I actually have a lot more access to survivors who function in a lot of different areas as advisors to the more survivor-centered care. So in that sense, I am able to access that kind of feedback, but officially within KP, it has not. Our efforts have not panned out to be as successful as I'd like.
So we in the health plans have advisory groups, but not one focused in this area. But whoever brought up that question, I thought that was great, because then I thought, well, why don't we have one? Let's, can we talk? So thank you so much for whoever brought that up.
Okay, thank you. We're kind of end of our time. There is one additional question from an attorney that's in the room. I would like to ask you to come up towards the front after we finish, and we can make sure that we answer that question for you. But as we close this session, I was wondering, is there any closing comments or thoughts that you want to convey to the audience?
I think for me, I really want to leave with partnerships and figure out how to work together, how to train, how to prepare my staff, how to bring more awareness, and then also with our medical groups or our FQHCs, that would be, a step for phase 2 as well. on our end, we recently, really quick, I'll share this, had a member whose husband's primary insurance was with us. Oh, no, he had different insurance, sorry. And she had Medi-Cal as well. And we were overseeing the Medi-Cal. So Medi-Cal was saying, no, you need to get care through your primary insurance. And she's like, no, I don't want to, right? For reasons we all know why. And so our team did work closely with the doctor to provide her the care that she needed and ensure that the husband would not know about that. And so those are instances we face, and having partnerships with you all, I think, would really also help guide and inform us on next steps. So really, that's all I wanted to share, and I'm thankful that I had an opportunity to be here and for me to just have awareness, because I'm, in healthcare, kind of focused on healthcare. And so this really kind of opened my eyes to the world that's out there, and also kind of brought back feelings of like, oh man, yeah, that I went through this. That's right. You kind of forget, right? So just thank you guys so much for your time.
Thank you.
Thanks, Blanca. So I would just say briefly that healthcare is the system wasn't set up to be patient-centered. Let's just say it, right? So really, and the system we have in general for survivors is very disconnected, and it's very difficult to navigate where you need to go. So I do agree. I think collaboration with our community partners and getting that feedback going in both directions is really going to be what's going to drive us forward. And I think our patients are forcing us to do this as well. And one thing that I really love about how digitally connected younger people are is they're coming to us and really forcing us to move the needle because that's what they expect and that's what they demand. And I definitely honor that. And I think that's what's going to drive us together. So our community partners and our patients are going to force us to do what we need to do.
Thank you. So as we bring this to a close, I just want to say that today, please network, and even beyond the day, if you have a healthcare partner, please extend an olive branch to them and begin the conversation. Systems change is hard work. We started with a collaboration many years ago, and it takes working on that collaboration every year. And you make steps forward, and leadership changes, and you go back a little bit, and you continue to inch to success. But the idea is to keep going. And so we leave you with the barriers are out there, but the people in the room here today and our partners, we really have the expertise to change things. We do need to look at the financing, but what we can do, let's do. So thank you so very much for your attention.
We want to thank our sponsors, the Blue Shield of California Foundation and the National Health Resource Center on Domestic Violence.